Hi, everyone. I'm Darlene Hutton with QRS Educational Services, and this recording is being done from the College of Nursing Students Association annual conference that was just held in Saskatoon last week. During my talk, Beyond Bedside Nursing, there were quite a few questions that were asked, and we did not have the opportunity to answer them or to discuss them. So that's why this recording is being done. If you have any questions afterwards, please reach out to my email and I'd be happy to discuss further with you. So one of the questions from the group was, what advice do you have for someone who is keenly interested in research, but is not sure where to start from? So if you're interested in research, begin right where you are. Pay attention to the questions that keep coming up either in class or in clinical. Why do things get done the way they get done? They become seeds of great research that you will maybe be conducting down the road. But start by getting comfortable reading research rather than trying to do the research right away. Pick an article or two that is related to the topic you care about and focus on understanding the questions that are asked. You don't have to understand the statistics at this point. And over time, your confidence in understanding the value of quantitative and qualitative research will be discovered and will grow. You also want to try to seek out opportunities to connect with faculty, clinicians, or researchers and see if you can assist in any way, possibly doing literature reviews or data collection. Those provide invaluable exposure to you. I asked at the talk if anyone is not currently on LinkedIn, and that was your project to ensure that your LinkedIn profile is up to your current standard of what you've been doing, either as a student nurse or volunteering in any kind of capacity. On LinkedIn, you want to follow researchers, research organizations, universities, and hospitals, and individuals that are doing research themselves. You can reach out to them with thoughtful questions. You can comment on their post and build connections. Often, the opportunities to participate in research arise simply by showing that you have an interest and you are visible. When I did my first research project, it was because I had an interest in seeing the relation between the development of critical care psychosis and our very strict visiting hour policies. We did a 6-month pilot project where we had open visitation policies, 24 hours, they could come at any time. And we saw an immense reduction in this phenomena. That was the first research paper that I presented and published in the Canadian Association of Critical Care Nursing. In 2008, as an educator, I was also in my own business, QRS Educational Services, doing a lot of teaching on cardiac rhythm ECG assessment. One of the areas that I noted there was a gap in was the interpretation of one of the 3 cardiac intervals, specifically the QT interval. As a CCU nurse, we would always be looking at the QT interval every time we had a patient on an IV antiarrhythmic medication such as lidocaine. But other than that situation, the QT interval was not routinely monitored. So it became an issue for me, and a question was, why is this not being routinely measured? When we measure the PR interval, we're always measuring the QRS interval. And when you look at the QT interval, of the 3, the QT interval being abnormally prolonged bears the highest risk of patient involvement, patient risk with cardiac arrest. So in 2008, after polling over 1,200 nurses Canada-wide, that article was published in the Canadian Association of Critical Care Journal. And then over 11 years later, 2021, a subsequent research paper was also developed, now making it more globally apparent that this is not routinely measured and looking at some of the factors preventing that. So you don't have to wait to feel ready to do research. Research is learned by doing, asking questions, and sometimes you're going to feel unsure. Curiosity, persistence, and networking matter far more than having it all figured out at the start. Another thing that I also want you to be part of, if you aren't already, is download Medscape, Medscape. Um, and there are all sorts of different areas within that organization that will reach out to you in terms of your interests. So for me, it's heart failure, atrial fib, coronary artery disease. And I will routinely get updates on new guidelines, new research that is being published. So that is a wealth of ongoing personal and professional growth for me to be participating in that. So the second question, are there specific questions you can ask yourself to reflect on whether to try something new or whether to stay in your current job? And that is a really deep question. I had to give that one a lot of thought. When I have made changes, most of my changes that went from one area of work to another really occurred in the first 10 years, 15 years of my nursing life. And I would ask myself a few questions. What will I learn in that new role? Will it challenge me and help me grow professionally? What are the risks of leaving where I'm currently working? And what are the professional benefits of going to this new place? Most importantly, will this new role align with what I love doing? For me, learning something new has always led to professional growth. And for me, the first 6 months in a new role has always been about learning that new role, figuring out the workflow, the expectations, the culture. While the next 1 to 1.5 years have always been about gaining confidence and truly seeing my development. And literature has documented this very well. Some opportunities for me have been temporary or contract based, which means that I've been able to explore something new while still being able to return to the previous role that I enjoy doing as a CCU bedside nurse. Oftentimes, you can wear multiple hats at once, and that's the beauty of nursing. At about the 12-year mark, I'd have to say, I was simultaneously wearing multiple hats. I was the nurse manager of CCU Step Down. I was also slowly growing my business, QRS Educational Services, and doing that on occasion, taking vacation time. I was also working as a research nurse, just filling in documentation from patients' hospital charts to the study charts. It was really challenging, but I knew that these super stressful bursts where I was really being pulled in multiple directions were short term, and each pushed my growth and professional confidence further. But staying in your current role doesn't mean you can't try something new. You can propose improvements to processes you could see being done differently. You can run educational sessions for your unit. You can share topics that you've learned about and present it to each other. Or you can take on leadership roles through committee work. These experiences allow growth and changing without changing your job. Honestly, I could have stayed being a CCU bedside nurse my entire career, but I personally would feel that pull every few years. And so I would stay in CCU and then I would start working casual in Emerge, in ICU, in PACU, still staying to where I was comfortable being. So, next question. What was my best approach, or what is your best approach to the toxicity as a new grad nurse? Um, this is a really honest answer. I didn't handle that toxic experience that I shared with you very well at all. It occurred about 2 years after I was a new grad. The first 8 months I worked as an agency nurse because there were no jobs. And then I worked for about a year and a bit in a medical unit, which I loved. I loved the staff. But I wanted to be in CCU. So when I did land that job, that's when my toxic exposure occurred. I didn't even know back then that this was unacceptable behavior. I didn't know what burnout was. It was never discussed. I thought it was me. I became afraid to ask questions. I retreated within myself to avoid conversations. And I would actually call the unit and check the schedule in advance to see if my next shift was with that nurse. I lost sleep a few days prior to going into work with her. At the time, I didn't have the tools, the confidence, or the perspective to navigate that situation effectively. As I mentioned in my talk, I was really close to leaving my profession because I thought it was me. It was a friend who helped me. She saw that I appeared pretty flat and I questioned her. I was honest, not sure that I was a good nurse. And she told me to leave that toxic environment. And I went to the new hospital where she was working, and it was like night and day. Time did heal me from that experience. I did notice in my new CCU, I was feeling guarded and lacking confidence for a short period of time. I was the youngest nurse, which didn't help the matter either, but I did have supportive team of CCU nurses, and I did gain my confidence later. Decades later, as an experienced nurse, and now I was working as an outpost station nurse, I faced a similar toxic experience. This time it was with the manager of the outpost station. I'd already been a manager, a business owner for over 20 years. I was an ACLS instructor. Yet when she abruptly slammed the door in my face after I asked her about missing supplies for a patient that I had to do complex wound care for, I was shocked. I was stunned. But this time I was in a different headspace. I noticed the other nurses working there, how they observed the interaction. And while they didn't say anything or speak up at that time, they did reach out to me after the clinical was ended. They supported me. They asked me if I wanted to go for a walk with them. And that really helped me to decompress. I felt their support. And they also reassured me that this manager treated contract nurses the same way. And they encouraged me to reach out to them anytime. They told me that they would be there to support me. That meant the world to me. For the next few days, I kept my distance every time I'd go into the station, and I would focus on staying professional and protecting my own mental space. And things shifted on the fifth day after three critical care patients presented in 2 hours. The manager kind of had this frightened look in her face, and she came to me for help, admitting that she wasn't confident caring for the patients as I was. And she asked me if I could help her. And over time, I also discovered that the brunt of her toxicity came from her own self-doubt and her own lack of confidence. And while that didn't excuse her behavior, it did help me understand her on a deeper level. Moving on from that day, the remainder of the contract there was uneventful, and we actually developed a good working relationship. That experience reminded me that having confidence, maintaining professionalism in the face of toxicity is really important. And really important is seeking out support from colleagues and taking a step back when needed to that can make all the difference to you. You need to have a support structure. Do not handle this alone would be my best approach to handling toxicity for anybody who is facing that. So I hope that answered that question. Next question. If the therapeutic relationship between the nurse and patient ends where their care and stay is over, what does it look like in research? So I had mentioned that some of the research studies I participated in, I would see patients for as long as 6 years, seeing them maybe monthly or every few months. So in research, the nurse-patient relationship can extend much longer than in a typical clinical encounter. And throughout the study, I was always transparent with the study subjects, the participants, about where we were in the study, what each visit would involve, and what the final visit would look like. And at the final visit, it was always similar to other visits. I would dedicate a set of amount time just to sit with them and answer any questions and discuss anything that they wanted to talk about. I'd also make myself available after the study concluded, and if they had any additional questions or needed clarifications, they always knew how to reach me. For the majority of participants, I wouldn't see or hear from them again, but knowing that they had the space, the time, and support throughout, even at the end of the study, it helped maintain trust and a sense of closure. So, in research, while the therapeutic relationship may not continue indefinitely, it is intentionally nurtured over time with transparency, respect, and accessibility being central to its quality. Question 5. What is your advice for students who want to do non-bedside nursing jobs, such as a director of patient care, a manager, or a nurse coordinator? And my advice for students who are interested in these types of roles is to first gain solid bedside experience, ideally for at least 2 years. This allows the first 6 months to really understand your unit and the role, and then another year and a half to build that confidence. Having the bedside experience gives you a deeper understanding of what frontline work actually involves, which is invaluable when making decisions that affect patient care and staff. For the 2 years, during the 2 years, you want to take advantage of opportunities to grow beyond your bedside duties, participate in or create research projects that explore questions you have about processes that could improve patient outcomes. Join committee work, collaborate with educators, and share knowledge with your colleagues. It's almost like mentoring your peers in a small way. These experiences will prepare you for leadership roles and help you develop skills that go beyond direct patient care. Also, you want to use LinkedIn to find leaders and managers that you respect or you aspire to become like. Follow them or observe them in your workplace. Learn from their style and seek guidance when appropriate. The combination of bedside experience, active professional development, and mentorship will give you a strong foundation for transitioning into these non-bedside roles successfully. So I hope that answered your question. Research projects that explore questions you have about processes that could improve patient outcomes. Join committee work, collaborate with educators, and share knowledge with your colleagues. It's almost like mentoring your peers. Let me see the next question. As a traveling nurse educator, how did you make your connections with various organizations? So when I first started as a traveling educator back in 1993, there was no social media. There wasn't even PowerPoint. So building connections back then looked very different to how it does today. The seed was planted from an identified need at the hospital where I worked, and with the assumption that that practice gap that I had identified at that time, I didn't think that it was just unique to our hospital. I made an assumption that this practice gap was something that all nurses in the emerge department faced, pertaining to STEMI recognition on the ECG. So I took that risk, I developed the course, and I taught it in different cities in Ontario. Each session was sold out, which confirmed the need for this education. But the next step was making sure that this content truly met the needs of each audience and offering these courses repeatedly each year. So over time, and it was about 5 years, there was a snowball effect. And by word of mouth, it was now coming back to me. People were now emailing, can you do this course in our area? So today with social media, with marketing and advertising, even though it's time consuming, it is necessary to maintain visibility. It's also critical to stay connected with your clients and maintain an open door approach so that they feel comfortable reaching out with questions. Annual updates to my courses are important to ensure contents remain current and I use education-based newsletter to keep in touch and nurture these professional relationships. The combination of relevance, accessibility, and consistent communication continues to sustain my connections with organizations. And one last question that was asked to me, she walked down to the Da Vinci room as I was sitting at my booth, and she stopped and she said, "So what was your favorite research project that I participated in?" And I had to give a lot of thought because so many of them have been extremely impactful. While the fibrinolytic trial, there were 4 trials in total, and these were international multi-center trials with over a combined 40,000 patients participating in them. They were impactful in improving outcomes, in reducing mortality. They were really an amazing group of trials to do. But I have to say the most pivotal trial was the one on heart failure. And even though they were smaller patient numbers, the first severe heart failure trial that I participated in was called the Copernicus study. We were looking at placebo versus beta blocker, and the only endpoint was mortality, which seems really dismal, but given that particular patient population, a new diagnosis of severe heart failure would result in 50% mortality within 2 years. And we would see this in so many patients at that time. There wasn't really a lot of interventions or new treatment classes. And the beta blocker therapy in severe heart failure studies was the pivotal study where researchers were able to prove that not only does heart failure worsen because you've got a weak heart, but it also worsens because of the neurohormonal effects worsening heart failure propagates. And the classes that we now have for management of severe heart failure, whether it's for preserved or reduced ejection fraction, it continues to be mainstay in our current evidence. So I'd have to say heart failure was probably one of my most favorite trials because I physically saw patients coming in at the beginning of the study, not being able to walk for 6 minutes without having to stop because of shortness of breath or chest pain, and seeing them 6 months later having sort of pep in their step. To be able to see that was truly remarkable. So in ending, I hope that all of your questions have been answered. Reach out to me again. You will see the email link that you can contact me if you do have any questions. So thank you very much.